It is my pleasure to introduce Dr. Pam Stein, who spent 13 years working as an attending dentist at 2 nursing home facilities after receiving her DMD from the University of Kentucky College of Dentistry. In 2009, Dr. Stein received her Master's of Public Health and is currently an associate professor in the Division of Public Health Dentistry at the University of Kentucky College of Dentistry. Dr. Stein teaches geriatric dentistry and public health dentistry. Please join me in welcoming Dr. Pam Stein.
So thank you to Delta Dental, and thank you to you guys for inviting me. I felt very, very welcome. In the South, we pride ourselves on hospitality, but I must say, you guys have done a great job making me feel welcome here. So I'm going to talk a little bit about a pilot program that we developed in Kentucky. We had a small grant from something called the Dental Trade Alliance Foundation. That is a national group of dental corporations like Henry Schein, all kinds of different, Patterson, all kinds of different dental suppliers come together, create this foundation, and every year they give a grant or two to promote oral health in vulnerable populations. And a couple years ago, we received that grant, and we did some work in nursing homes, and I'm going to share with you some of the things that we did and some of the things that we found. So we're really going to talk about 2 main things today. The first, and you may be familiar with some of what I will talk about, so it might be a little bit of a repeat of what you already know. But I'd like to talk a little bit about systemic outcomes and how those are affected by oral health, because I think that is foundational in terms of convincing nursing homes how important it is to achieve good oral health in their residents. They understand the systemic relationships. That's really foundational in developing that partnership. And then I want to tell you a little bit about our model. Our model of oral care in nursing homes, and this was not providing professional dental care, but improving daily oral hygiene. And that was to have one designated nursing assistant who provided the oral care for the nursing home residents. And we'll talk a little bit about some of the comments that I heard earlier today about overcoming barriers with nursing assistants who just don't seem interested or who are actually put off by working with the mouth. I think this model might really be a good solution to that problem. So we'll talk a little bit about that, how we were able to develop a partnership with the nursing home, and a little bit about how we made a case with the nursing home that this was really important, because our funding did not include money to pay the nursing assistant. It was a small grant. So the nursing home actually had to pay this nursing assistant to be designated to do nothing but provide oral care. So we really had to get buy-in. But first, I just want to remind everyone, I think OBRA has been mentioned several times, but I just want to give you a little bit more information about that. Providing oral care, and by that I do mean daily oral hygiene, is not optional. It is mandated by the federal law for nursing homes who receive federal funding, Medicare, Medicaid, and almost all nursing homes do. There are a few private ones that don't. So this Nursing Home Reform Act, which included many other things besides oral care, the Omnibus Budget Reconciliation Act, known as OBRA, was enacted in 1987, and the final regulations took effect in 1992. The mandates included that facilities must provide routine and emergency dental services for their residents, and this is if they receive federal funding, which means they have Medicaid or Medicare patients. They must either provide that in the facility, or they must make arrangements for dental care, routine and emergency, to be provided for their residents. They must also help those residents make those appointments and provide transportation. That can be costly. And they must promptly refer residents who have any problems with their dentures. And the bottom one is the one we really focused on, and that is that the nursing homes must ensure that patients who have difficulties with activities of daily living, their personal hygiene, including oral hygiene, that must be taken care of. So the appropriate aid must be given to residents to make sure they have oral hygiene as part of their total personal hygiene package. And this is really a good law. It's important that all of the parts of OBRA are important, but this part about making sure residents keep their teeth brushed or are assisted in doing that is really important because of the health consequences of a dirty mouth. A dirty mouth could be making residents very sick. In fact, it probably is. I'm sure many of you are familiar with the systemic health benefits of keeping your mouth clean, but this is particularly important in a frail elderly population, many of whom have lots of chronic health conditions. So one of the points I try to make, I have developed some educational materials along with some of my other colleagues for nurses and nursing assistants and physicians. Actually, there's a really nice module online for physicians called Smiles for Life. If we have any physicians in the audience, you can get CME credit for that. But one of the things we try to get across is the fact that the mouth is connected to the rest of the body, and we've created an animation. And I'd like to show you that animation now, and that animation is available to any of you online. I'll share with you the website that we've created that is a toolkit with all kinds of free resources for nursing homes, for dental professionals, and for families. So many of the things that we'll talk about will actually be available on the website for you to use. Getting the point across to nurses and nursing assistants that the bacteria that is in our mouth doesn't stay in our mouth. It can be aspirated, and that can cause respiratory problems, but also it continually drips into the bloodstream. And that has been shown to cause multiple problems, clotting within the arteries, problems with glycemic control, and also potentially hardening of the arteries. Great. So what I'd like to show you now, share with you, is the animation that we created, and this was specifically to educate nurses and nursing assistants. We spend a lot of time in nursing homes, and one of the buzzwords in nursing homes is wound care. Wound care. Talk a lot about wound care in nursing homes. And also a lot of people get pneumonia. So my dental colleagues and I really try to think of how can we, with our dental verbiage, communicate to the nursing professionals that what we have in the mouth is essentially a wound, and that needs to be cared for just like a wound anywhere else on the body. A wound in the mouth is also going to be very detrimental to their systemic health. So we created this animation, and on the website that I will share with you, there is a talking through version. So if you wanted to show this, and there would be a voice talking through the person for self-study, or you could, if you were a dental professional and wanted to show it, you could play it without the words and you could talk through it yourself. So the idea is, and this is the wound on the hand, that the surface area of the wound on the hand is very similar to the surface area to the wound in the mouth if a resident has generalized periodontal disease, and many residents in nursing homes do. So we've colored the plaque in green, and we have the little rods showing the bacteria. So then the next slide shows those bacteria are in the pocket between the tooth and the gum. They reside there, but they don't stay there. The bacteria really all the time, continuously, are dripping into the systemic circulation. So those bacteria, and by the way, they're very bad bacteria, get into the bloodstream and then have access to the entire body. And that is not without consequence. That causes all kinds of problems for the residents, for any of us who have a lot of plaque in our mouth that's not brushed off. So these very residents who already have lots of chronic conditions, like diabetes. Maybe they're at high risk of stroke, high risk of aspiration. Now you have plaque that's not being brushed off, and this is really a big risk factor for exacerbating their chronic conditions. Okay. Now, one of the things in the work that we've done in nursing homes, in addition to wound care, we found that there are a high number of residents who suffer from diabetes. Now, I don't know if it's just because Kentucky has a very high rate of diabetes. We have an obesity problem in Kentucky. I think we have the highest rate of diabetes, third highest rate in the nation. So I'm not really sure how Iowa fits into that, but probably most nursing homes have several patients that have diabetes. And so one of the concerns is trying to get glycemic control really under control, get the sugar levels under control. So there have been multiple studies. There's really some good research that connects diabetes to glycemic control. And so this is another point that we tried to get across to the nurses that we worked with, and that is if you're having difficulty getting control of the blood sugar for your residents, consider getting their mouth cleaned up. Having the teeth cleaned professionally and then good oral hygiene could really make a difference. In fact, there have been studies that have shown this, that treating gum disease, in fact, really does improve blood sugar levels. The other thing about diabetes is, and particularly in a frail population, you worry about complications from diabetes. So there was an 11-year study, this was published in 2005, that found that individuals who had severe gum disease were more than 3 times as likely to have a complication, a kidney problem or a stroke, some sort of macrovascular or microvascular complication, and much more likely to die if they had severe periodontal disease and diabetes. This, to me, is the big one, though. I think diabetes, we can make a strong case for that in the research, but to me, the big case in nursing homes is pneumonia. Lack of oral hygiene is a significant risk factor for pneumonia. Bacteria can be aspirated into the lungs, so these bacteria get into the saliva. Saliva can be aspirated into the lungs. This is important because pneumonia is the #1 killer in nursing homes, so this is not a small problem. Wound care and pneumonia were the 2 things that we heard over and over and over when we were working in nursing homes in Kentucky. There was a really nice study done it's recent, 2008. It was published in the Journal of the American Geriatric Society, and it showed, it was a systematic review of all research that had been done looking at oral hygiene and respiratory disorders, and does oral hygiene make any difference? And they found 15 different studies that showed brushing the teeth, simply brushing the teeth, reduces pneumonia in nursing homes. In fact, in this paper, the author stated that approximately 1 in 10 cases of death from pneumonia, and this was in hospitals or nursing homes, could be prevented by simply improving oral hygiene. So that's a pretty impressive statistic, and I think something, if you're going to try to work with the nursing home and convince them of the importance of daily oral hygiene for their patients, this article would be a good one to have. So what I did when I worked with the nursing homes is I didn't just take the whole article, because they're not going to read the whole article. You could take the whole article and highlight the finding, or just give them a sheet of paper that has 2 or 3 really strong evidence articles, the main finding and the citation. This was the one that really motivated us to do our particular model of care. This was a study that was done in Florida. And in this study, the model of care was there was a designated oral aide. So there was a nursing assistant whose only job was to provide daily oral hygiene to the residents. So there was 2 different wings of the nursing home that had that kind of care, And then the other two wings of the nursing home did not have that kind of care. They didn't specify in the paper whether or not the two wings that didn't have the designated oral care aide, if they just got oral care as usual or what they got. But the finding of the paper was that the residents who had daily mouth care provided by the designated oral care aide were much less likely, about 3 times less likely to die from pneumonia than the ones who did not. So that we thought was pretty impressive finding. So we decided that we would attempt to replicate this model. And I have to say, I can't remember who it was in the audience that stood up and said they had given the education to the nursing assistants, and I could feel the discouragement from that person. And may I say that I have been there many times. I have given so many of those in-services for nursing assistants and just felt like I had really gotten nowhere with it. And then I would go back to the nursing home to check my patients, and I was assured that I had gotten nowhere with it because there was no difference in what I was seeing in my patients, and I just was so very frustrated. And that's why this model of care really appealed to me, because when everyone is accountable, no one is accountable. So you go, and nobody is really the person that you go to say, you know, you were supposed to do this. Well, everybody is supposed to do it. So this model of care really appealed to me. Having a champion for the oral health care, having someone who really actually wants to do this service. And I know most nurses, nursing assistants, or at least some of them, are turned off and don't want to do it, find it distasteful. But we were able to find someone who actually didn't mind it. And I think she really enjoyed it. She's, you know, kind of like one of us dental people. It wasn't so bad. And she really liked working the residents in that way. And so in that way, we found someone who was willing to do it and who was held accountable, and that we could spend a lot of time with, really educating her and making her part of our team. So I'd like to tell you a little bit about how that went for us and some of our struggles and maybe some of the things we learned. So if you decide you might want to try something like this, maybe you could learn from some of the things that we have experienced. Our first step was to develop a partnership with a facility. So the facility that we chose, we just didn't randomly go in the phone book and look for nursing homes. We looked for nursing homes who had a very good reputation, who were 4 or 5-star nursing homes, who had very few problems, and who really seemed to care about the quality of care for their residents. And so we were fortunate in that we were able to find a nursing home, or actually a couple of nursing homes, that were really good to work with, and they really, truly did care about their patients. We met with the administrator, and it's no accident that that picture looks the way it does. That's the way I felt, totally intimidated, like I was going for my dental school interview, trying to make a case to the administrator, because remember, we were asking the nursing home to pay this person to do this service. We could not offer the $25,000 salary. We just didn't have that much funding. So we really had to try to convince the nursing home administrator that this was a good thing, and I'll tell you a little bit more in the coming slides about how we did that. We also met with the director of nursing and the social worker. Director of nursing was a very busy person. In one facility, it was like pulling teeth trying to get an appointment with her, and I would go and had an appointment for days, and I would go and she would not be available. So that was very frustrating. So what we found was the social worker was the go-to person, and she was very available to us, and she really was our point person. The other nursing home that we worked with, the director of nursing was always available and very excited to work with us and very much a part of our team. So I think it needs to be one of these three people, or maybe even assistant to the director of nursing or an assistant to the social worker that becomes the point person. So all of these individuals need to be part of the team and part of, in the know on what's going on and why it's going on and have buy-in. But there really needs to be that one person that when you need to call someone or you need to meet with someone, you know that you can count on them and they are available. Some of the benefits to the facility. So here's how we made our argument. Nursing homes know that they know about OBRA. They know about the dental requirements, and most of them really want to fulfill these requirements. No nursing home wants to have to pay a fine and have a penalty and not be in compliance. So we just reiterated that, our partnership with them would be helping them to comply with the law. We also talked a bit about the public relations and marketing aspect, creating a positive facility reputation. And in fact, when we started our pilot program at one of the nursing homes, the Herald Leader was actually there. This is our big paper in Lexington. Lexington is about 200,000 people, so it's not a really big place. But the Herald Leader has probably about 1 million readership throughout Kentucky. And we actually had a picture of one of the residents with the social worker talking about this new pilot program. It was a big deal. And so the facility got really good publicity. And I think probably the timing helped. Right before we went into the nursing home and started doing this project, there had been a death in Kentucky in a nursing home related to an oral problem. A gentleman had, I can't remember if it was a gentleman or a lady, but there was a resident who had a denture. The nursing home didn't know they had a denture, and so an infection had progressed under the denture, and I think the resident eventually died from septicemia. So we were kind of set up for some good PR going into the nursing home and trying to be proactive. Quality of care for their elder residents. This is another benefit to the facility, being able to really provide a good quality of care for their elder residents, including their systemic health, not just their oral health. Now, I think Maren touched on this a little bit before, and that is the cost benefit. So, as you know, the way our world works is money. Money talks, and if you can start telling people how you're going to save them money, they suddenly will start to listen. So we try to really think of ways that providing daily oral hygiene could be cost efficient for facilities. And we've come up with a few things that might be helpful to you if you're at some point trying to make the same argument. In Iowa, if a nursing home census is above 95%, that facility is only reimbursed 25% of the actual per diem rate for a bed hold day. And if the census is below 95%, no payment is made for the bed hold, and the nursing home is required to hold the bed for 10 days. Now, why does that really matter? Well, if you go back to the slide on pneumonia, and if poor daily oral hygiene actually does significantly increase the risk of pneumonia, and pneumonia means going to the emergency room or the hospital for a stay, and it often does, that means the hospital is going to have to keep the bed for at least 10 days. The nursing home is going to have to hold the bed. And they may get only a percentage, or they may get nothing for holding the bed. And in Iowa, 50% of nursing home residents are Medicaid. So this would apply to about half of the residents. So there is a cost benefit of keeping residents out of the hospital, out of the ER. And if brushing the teeth helps keep that from happening, then there is a cost benefit to that. Other cost savings, OBRA mandates that the nursing home provide transportation to a dental office or to the hospital And if you're providing daily oral hygiene, there should be fewer dental emergencies and dental problems, so there should be less transportation. Transportation can be very expensive. And in addition, I think Marion maybe touched on this, the nursing home also has to send an aide with the patient. So now there's a workforce issue back at the facility because they're down by one, or they have to have someone come in to take the place of the aide that has gone out with the resident to a dentist. And I added this just recently because, as you know, we now have President Obama as our president for the next 4 years, which means health reform is probably going to stick around. We're not talking so much about repealing that anymore. We're now talking about how it's going to be implemented. So I had this really nice lecture. It's on the receiving end of a great lecture from one of our experts in Kentucky on implementing healthcare reform and what that means to physicians and to dentists and to other providers of care. So I asked him specifically what healthcare reform would mean in long-term care in terms of going back into hospitals and that kind of thing. The big point that he made in that lecture was with healthcare reform, hospitals and providers are going to be paid based on outcomes. And actually, Mesa talked about outcomes and being reimbursed and on outcomes and not by procedures. And that is the way healthcare reform is going. If a patient is treated for something and then they have to be readmitted to the hospital, then that's just too bad. The hospital and the physician have already been paid a lump sum to take care of that patient, and the readmission is just going to be then something they have to take care of that cost themselves because they've already been paid to take care of the patient. So I brought my notebook, so I wrote down exactly what he said about nursing homes. Quality of care and healthcare reform for long-term care means that over a certain number of hospital admits for pneumonia, their reimbursements would be cut. So they have a real incentive to decrease the number of hospital admits in terms of reimbursement. So that's another benefit, cost benefit, is keeping the rates of pneumonia down, the rates of going into the hospital really for any reason, and particularly hospital readmits, down. Other ways that we encouraged buy-in from the facility leaders, we asked for advice from the leaders. So we didn't go in with our plan and say, this is how it's going to be. We sat down with them and really asked for their input and advice as to how this would work within the culture of their facility, and try to really have a legitimate partner from the administrative standpoint and the leadership in the nursing. And this is key. This is the key. Identifying the nursing assistant to be trained. So you have to find someone. In our case, it was a nursing assistant who had been at that facility for about 30 years. So there's a high turnover with nursing assistants in long-term care facilities, but this lady had been there for a long time. The residents loved her. She had a really good rapport with them. She knew when was the best time of the day to do something difficult with them. She knew how to talk with them, how to manage care resistance. She's just really great, and she didn't mind working in the mouth. So she kind of self-selected, really. She was interested in doing it. The nursing home suggested her, and then we talked with her, and she was really kind of excited to do something different. And she got additional training, and she became the geriatric oral health specialist, or the oral champion, at that facility. So we created a curriculum for this nursing assistant. In creating the curriculum, we researched the literature for successful elements of past programs, things in the literature that come up over and over again about good educational programs for nursing assistants regarding oral health are things like Show Me, hands-on training. Someone else mentioned that today. very important. Show me how to take care of residents who are care resistant. I have to have time to do this. I have to have buy-in from the administration and my director of nursing, because if they're pulling me to do other tasks, I don't have time to do this or even take the training. So those are the kinds of things that we incorporated into our program. So we had 4 self-instructional PowerPoints. These are all available online for free for any of you to use. I'll give you the link to that in a moment. We started with the importance of daily oral care and tried to use the Iowa plain and simple language mindset while we were doing that. Guidelines for daily care. So we showed in the PowerPoint how to do the oral care, checking for problems, things like how to do an oral exam, looking for really obvious things, and then also residents who require special care. For instance, residents who have had a stroke, may have one-sided neglect, or residents who have cognitive impairments, or who are blind, who have hearing impairments, and those kinds of things. This care resistance problem, it is a big deal, not just for nursing assistants, but also for dentists, and it can really be difficult to brush someone's teeth. I think Maren said, you would think brushing someone's teeth is not a difficult thing to do. Well, I would challenge anyone to go into a nursing home and try to find 10 patients and brush their teeth. It's not as easy as you think. And they're frail. There are a lot of considerations. Sometimes not only is it not easy, it can be dangerous to provide oral hygiene, and I'll talk a little bit about that in a moment. There's a safe way to do it. Rita Jablonski is a nurse. She has her area of research. She has a PhD. I think she's at University of Pennsylvania. Is anyone familiar with Rita Jablonski? Oh, she has. Okay. I think this woman is fantastic. Her area of research is all about care-resistant behavior. And she has created a video, and she has free on this, it's called the Portal of Geriatric Online Education. Any of you could go to this and pull up Rita Jablonski's work. If you want some good information on how to provide care to care-resistant patients, she's your go-to person. Other people have written about it, but she's really gotten a lot of funding to do research as to the best way to provide dental care, daily oral hygiene for patients who are care resistant. So I would encourage you to look up her work. She was instrumental in helping us educate the nursing assistant in terms of care resistance. I think this part is essential, the hands-on training. Going in and just doing the PowerPoint, I did it for years, just stood up and talked, but it didn't really, the eyes glaze over, they lose interest. Some of it is distasteful, like you said, looking at the pictures of the mouth, they don't even want to look at that. But if you can go with the nursing assistant to the bedside of the patient and actually show them how to do it. In fact, I had a fantastic hygienist that was working with me on this project. And she went with the nursing assistant into the bathroom and showed the nursing assistant how to provide her own oral care. And we've already talked about that today, using disclosing solution, showing her how to use proxy brushes, showing her how to use floss holders, the right way to brush her teeth. That was huge, just doing that 10, 15-minute instruction for the nursing assistant for her own oral health. We spend a lot of time in the nursing homes during the time that this pilot project was in place. We traveled room to room to help the nursing assistant deliver care. We went back to do checks, just looking the mouth of some of the patients to make sure that the plaque was reduced. We felt like she was actually getting it, and if there was a deficiency, it was fine. We just worked with her all the more and gave her additional coaching. We really tried to be supportive and encouraging to her and provide the tools that she needed. I will say that nursing homes often don't buy the highest quality toothbrushes and toothpaste and that kind of thing. So what our grant funding did provide were some really nice spin brushes and good toothpaste and floss holders and proxy brushes, mouthwash. So we did have that. We did have a lot of really good oral hygiene tools. We talked with the nursing assistant, and we also talked with other staff about their struggles, so she could come to us if she was having trouble with a care-resistant patient or she just didn't feel like she could get the denture clean. We also talked with residents themselves, and we talked with the residents' families about their concerns. And it's really interesting. I really liked the video. Let's see. I think Dr. Helgeson showed the video of the adult lady who had the mom who had cognitive impairments, and she was so good about brushing her teeth. And we found that to be true some of the time, but surprisingly not all the time. It seems that some family members, even though they would come visit every day, they just felt like that was the job of the facility, and they did not, perhaps they felt that was distasteful too. I don't know. So it's wonderful when family members can be educated on the importance of providing this care and also on how to do it. And we've created a video for families, which is also on the website. But just knowing that some families, even though they love their parent or their loved one very much, they're not going to brush their teeth. They're not going to do it. So it's important that the staff, someone in the staff does have the responsibility to do it. We also tried to address concerns with leadership and sustainability. Would the nursing home continue to pay this person to be the designated oral care aide after we left and this program was over? And so we met not only with the administrator but also with the CEO who was over 5 nursing homes. And the 2 that we had were 2 of the 5 that they owned. So we were teacher, we were student, we learned a lot, and I really want to share with you some of the things that we learned. And I think I mentioned this before, but it's really, really important to establish a relationship with a point person at the nursing home. In one of the nursing homes, it was the social worker. We could not have done it without her. I could count on her to return my calls and my emails and to get things done for us. When she said that she would meet with us, she was there and ready to meet with us. At another nursing home, it was the director of nursing and the assistant director of nursing. So it's just very important that you have, if you can't find one person that you can communicate with and try to get things done with, it's going to be difficult. But luckily, we were able to do that. So we trained one nursing assistant that we thought was fantastic, but she only worked weekdays, and she worked 7 to 3. This is not enough. One person cannot do an entire nursing home. There were about 90 patients in this nursing home. So there was no way, and she wasn't just brushing their teeth. She was also flossing their teeth and doing the rinse, taking care of their dentures, and it wasn't a really quick service. Now, we could have abbreviated, and we talked about eliminating flossing and maybe just doing the brushing, but we just couldn't eliminate the flossing. We just couldn't do it. We just felt like it was too important. So we went ahead and did the flossing, even though it took time and she didn't have enough time to do everybody. So training the one nursing assistant was not enough. We learned that. In fact, residents some of them were care resistant and did not want her. Some of them kind of verbally abused her too. We had to deal with that. But most of the residents really liked having their teeth brushed. And in fact, they were asking to have their teeth brushed in the evenings. Well, our trained nursing assistant was not there in the evenings. And the other nursing assistants who worked in the evenings and on the weekends were being asked to provide the service, and we had not trained those folks, which made me really nervous because what if they're keeping the patient flat and they're not elevating the head of the bed? What if they're not, I mean, there could be, infection control things. And I just felt like, okay, we're going to have to train everybody, at least with some basic safety precautions, an abbreviated version to make sure they're not actually causing problems when they're putting things in the mouth. Water and toothpaste, you don't want them to cause an aspiration. So we felt like even though we'd spent all this time on one person, because they were asking for the service at other times, it was essential that we give at least a basic safety training for everyone. So we developed a shorter, more basic curriculum. It was 30 minutes, and we found that that was even too long. So then we created a 10-minute video. It's actually 11.07 seconds or something like that. But it's a video that's online on our website. So if they only have 10 minutes, they can at least get the basics and understand how to provide this care safely. And this was, I had worked in nursing homes for years and provided care, and this is something I did not fully understand. And I haven't seen much about this in the literature. And that is that some residents are on a diet prohibiting thin liquids. And by thin liquids, I mean water. Water. So now, how are you going to brush somebody's teeth? I mean, we were brushing their teeth with toothpaste, letting them rinse with water. That seems pretty benign. Not so on a patient who's not allowed to have water. So a regimen which included mouthwash, that's a thin liquid, water, toothpaste, that could be a choking hazard. So now you can't do this one-size-fits-all oral hygiene protocol for everyone. And to make matters even more complicated, this status, these dietary restrictions change. So on Monday, maybe Mr. Smith can have thin liquids, and then next Monday, a speech pathologist evaluates him, and now he cannot. How can we keep up with this? How can we keep up with this? So I called around the nation. I talked to Barbara Smith at length about this. We talked about it. I talked to folks in VAs who provide daily, who do a great job providing daily oral hygiene care. And what I heard from many of these folks is that we moisten the toothbrush. We moisten the toothbrush with chlorhexidine. We don't use water to rinse. We're not having them use mouthwash. They could swallow the mouthwash. They may not spit. They may just hold it in their mouth. So when you deal with patients with cognitive impairments, they're more likely to have swallowing problems anyway and choking problems. So that's just a little pearl. Think about if, fluoride is wonderful, but we certainly don't want anyone to choke on fluoride toothpaste. So moistening the toothbrush, maybe with, we are actually doing another pilot program in the state of Kentucky now that's modeled after this. And I think what we've finally come to the conclusion that maybe the safest thing to do is use Listerine that has fluoride in it to moisten the toothbrush, and just not use the toothpaste. But I'm hoping we can still do the floss. I'm not certain about that. So this was something that actually really worried me, because the last thing we wanted to have happen is someone to choke while getting their teeth brushed or aspirate. Then no one would ever want to brush anybody's teeth. So that would just be awful. So we modified our curriculum to include information on safety precautions, things about making sure the bed is elevated. That was actually already in there, but this information about dietary restrictions. We created a YouTube video that described how to provide oral hygiene care, and that's the 11-minute one. And we developed a red safety precautions flashcard that was laminated and placed at every nurse's station. So when the nurse assistant goes in to provide the care, she can take that flashcard with her and knows these are the things I really need to watch for to make sure that I'm doing a safe job. Next steps. Well, our next steps include providing these training resources for free to dental professionals, nursing professionals, and families and nursing homes. And in fact, we now have that website up and ready for use. Anybody that wants to access it is free to. We're also collaborating with Medical University at South Carolina to train their nursing students there, not nursing assistants, but their nursing students and their nurse practitioner students to using some of the information that we used in this curriculum, but have developed it even further. So we're hoping that if we can start with the nursing staff that really are the leaders in the facility and help them to understand the importance. Perhaps they'll advocate in patient care conferences and hopefully advocate for daily oral hygiene as a way to obtain better health outcomes. So now, let's see if I can go to the website and show you just a little bit about what is there. Here it is. So if you want to find this at home, just remember University of Kentucky and Nursing Home Oral Health. If you Google those two things, this is what you'll come up with. Nursing Home Oral Health, University of Kentucky. It should either be at the top, first or second choice on Google if you Google that. So we created this site for 3 different groups of folks, for dental professionals, for nursing home staff, and for families. So with the understanding that not every nursing home has a dentist or a dental hygienist that is able to come in and provide education to them, many of the things that we have on the nursing home staff tab here are self-study. So there's a 30-minute version of our training, a 45-minute version, and the 90-minute version. The 90-minute version would be what our designated oral care aide, that was the extended training that she took. The 45-minute version is a bit more abbreviated, 30-minute, even more abbreviated, and then as I said, we had requests for something even shorter, and so we made the YouTube video. Just tried to really hit the most important things about providing oral care safely. So there are a couple of options. You can download the slides if you're a dentist or a dental hygienist and you want to go in and give this presentation. It's shovel ready for you. If you work in a nursing home and you want it to be self-study and just let whoever's in charge of their CE at the nursing home play this in their facility, this view video is a talking version through the PowerPoint. Then if you scroll down just a bit, here's the video. It's a YouTube video. Here's the wound care animation. So if you wanted to use that in education, you could click on that and use the wound care animation. And then there are some downloadable lists. So there is a task list. So this is actually a recipe card. If you have a nursing assistant who is going to go in and take care of a patient who has a denture, this takes that nursing assistant from step 1 all the way through, including infection control and positioning of the patient and everything. We tried not to leave anything out. So it's like a recipe card. And so we've created those for patients with natural teeth and people with prosthesis. I also have created a supply list for patients with partials and dentures and natural teeth. And then there are some downloadable forms. So we have created some competencies for nursing assistants. We have that red safety precaution card that could be laminated and left in the residents' rooms or at the nurse's station. We have a pre-test and post-test to assess knowledge attained during the training, a daily oral hygiene log, and a dentist referral form. Also some information about paying for dental care, and then some other resources. There's the Jablonski, the POGO site is on there. And this is the Smiles for Life training materials for physicians. So if you have some physician friends that are interested in oral health, Smiles for Life is a great, great site for them. It's free. They get CME credits for going through this online training, and there's everything from caring for children, oral health in children, through geriatric. The newest is the geriatric model. If you go to the family site, there's a downloadable checklist for families. So this is information that families should provide the nursing home when their loved one is admitted. So if you are a dentist or a dental hygienist and you have a patient who has a loved one getting ready to go into the facility, you might want to give them this checklist, because they need to provide the nursing home with information about whether or not their loved one has partials or dentures and other things that the nursing home needs to know about the oral care. So I think my time is up. Again, I appreciate your attention. I would be happy to answer any questions that you might have.
Hi, I'm a DMAC dental hygiene student, and like our instructor, Marilyn said, me and Sarah are going to go back and talk to our other classmates. But as far as, so this is kind of directed towards like any like nursing instructors or nurses that might be here as well as you. What can we do in our presentations next semester to help motivate them, and what are like the nurses, what do they want to learn, and what things do they see in the nursing homes or in the hospitals that we can take back and really help motivate everybody else?
Well, I think that's a great question for our nursing colleagues, but I can tell you from what I've seen in the nursing homes, making the correlation between wound care and the wound in the mouth seems to really resonate, and also talking about the systemic correlation between pneumonia and how brushing the teeth really helps prevent pneumonia. Actually, some literature talks about brushing the teeth preventing influenza as well. So those things really seem to resonate. I would encourage you to do hands-on training, not just talking, but showing and doing. And one of the things I failed to mention is that another thing that we learned while we were doing this project is you can brush the teeth all you want, but if you don't have a hygienist in there scraping the tartar, getting rid of the debris on the teeth, sometimes we just felt like we were very limited as to what we could do. And in fact, the research shows that the programs that are most successful are those who have hygienists going in and providing prophylaxis and scaling and the daily oral hygiene, and that just makes sense. And in the project we're doing in Kentucky, we have incorporated the hygienist coming in and taking care of the patients as well as the daily oral hygiene. So I think there's really importance of providing professional cleanings as well as the daily oral hygiene.
Do you happen to have ballpark figures on the average cost for a case of aspiration pneumonia?
You know, I do not. Do any of my colleagues?
Dr. Stein, this is the second time I heard your presentation. Very interesting.
Oh.
Yes. But there's one more thing is even more interesting. We did not know each other. We did not talk to each other. But we had an almost identical research program, just like you did.
How about that?
Yeah, we just recently finished that. And then very similar protocol and the setting. But our project was a little bit larger. We went to 3 different nursing homes. And also, we trained, in each nursing home, we identify 2 oral health aides, and we provide both didactic and hands-on training for them. And regarding the training, we have we have 2 persons in the training team. One is a dental hygienist. Another person is a psychologist who is the director of the local mental hospital. So then the rest of the thing are very similar. And then we also have a continuing education program coming out. It's called Mouth Care Without a Battle. something like that. Yeah, very similar to.
Excellent.
And then going back to the pneumonia question, I think we are actually have a RO1 application right now is under review, and then to study that, including the cost effectiveness analysis. So probably if we get it, maybe in the next few years, we probably will have information to answer that question.
Oh, that's wonderful.
Hi, I want to thank you. I learned a lot from your presentation, and I want to ask Maren, when she started out today, she talked about some bright spots in Iowa, and she also mentioned the Direct Care Workforce Initiative, which is a state initiative that's looking at the education and training standards for direct care workers across all care and support settings. And I think what you've presented here today is something that could align with some of those activities. And you've talked, several of the speakers have talked a lot about education and training of CNAs. And it makes sense that they should play a very significant role in oral health care for nursing home residents and people in their homes, persons with disabilities, kids with special needs, because they do provide, 70 to 80% of the direct hands-on care. But my question is, when do we get to the point where we're institutionalizing this a little bit more, the education and training into the CNA's credentials, so that that knowledge and skill is more portable and follows them from one consumer or resident client to another, from one facility or setting to another. And the other question I had was, again, one of the earlier speakers talked about a survey that was done of nursing home administrators and nurses and CNAs, and I just wondered what the return rate on the CNA survey portion of that study was. And I'm surprised that there hasn't been more said about staffing levels being one of the barriers, and the high turnover among that sector of the workforce, and being a barrier and having a huge impact on being able to deliver good oral care.
I think you're exactly right, and I just did not mention that, but that's a huge issue, the staffing. Not enough time, not enough staff, and they're focused on other things that I think perhaps they believe that the inspectors will focus more on, things like bed sores and so I think you are exactly right on the staffing issues. I think Dr. Helgeson and I were talking a few minutes ago, and he mentioned that there might be a way to have a direct oral care aide compensated. So you might want to mention something about that. That was very interesting to me, and I wasn't aware of what he was talking about. And that might handle the staffing issues a bit.
This comes under the heading of a thought, not an answer. There is a provision in the Social Security Act that allows people that are on Medicaid to use their Social Security income to pay for medically necessary care that's not covered under Medicaid or Medicare. And I think a strong argument could be made that effective daily oral care fits into that medically necessary envelope. And that's a private billing mechanism. It's not subject to Medicaid because it's not covered by Medicaid. So just hypothetically, you could design perhaps a system where some factor for that could be built in, and then either in a dental director model, maybe the dental director could supplement the salary of an oral care aide, so that they could be dedicated in that manner, and then have them supervised by the collaborative hygienist who's in charge of the screenings and assessments and so on at that facility. So you have the hygiene supervision of that person on a regular basis.
So they're really
just an
becoming
idea.
part of the dental team.
Right, exactly. They become an extended part of the dental team. They're analogous to the dental liaison. You mentioned, you need a point person, and they could be one of these various people. and we call whoever that is the dental liaison. And then they have responsibilities, you know, in that role under the contract. Anyway, it seems to me that having the oral care aide supervised by the collaborative on-site hygienist makes perfect sense. And if there's that supervision of them and then some dollars that supplement their normal pay, so they're a higher paid CNA basically. I don't know, it's an idea.
All right, thank you very much.